Do they need like a code?
Yeah.
We're going to do pull everywhere. Is that okay? Oh, cool. So that we can kind of see what y'all think as we go along. It's just like one generic one. I don't have like the questions plugged into it, and we'll just clear it in between. Okay. All right. Yeah. On the content review, it says that rheumatology is a whole 2% of what you need to know. Is a little bit offensive to me, but it's okay. All right. And like there were 10 things, list like 10 rheumatologic conditions, basically, or like learning objectives posted under that. So basically what I did is I've written one question about each disease for us to go over today. That's about all we're gonna have time to do. But I just did the whole lupus lecture recently, so hopefully we won't need to spend too much lupus time. But here we go. All right. This is a 7-year-old previously healthy boy who presents with 3 days of hip pain. He's been limping. He had a URI a week ago and he got over that just fine. He's been afebrile. On exam, he's holding his leg externally rotated and his hip slightly flexed. He has decreased range of motion in his hip. He's well appearing and the remainder of his exam is normal, including a complete joint exam. His lab evaluation is significant for normal stuff. An ultrasound of his hip shows a small effusion. So what do you think is the most likely diagnosis? Okay. Wait. Give more people time. Did you type it into here? Maybe my okay. People who are Zooming, Dr. Holloway is going to type the poll everywhere into the chat so you can get on there. All right. Most people are saying E, transient synovitis, which is correct. Does somebody want to kind of talk through how you came to that conclusion? What about this patient says transient synovitis to you? Yep, preceding viral illness, normal inflammatory markers, afebrile, it's only been there for a few days. Great, perfect. So transient synovitis is typically between ages of 3 to 8, so kind of your school age kids, a little bit more common in boys than girls. Pain in the hip and limitation of range of motion. You can get like post-infectious arthritis other places too, but the hip and the kind of this presentation is the most common thing and I think the most likely thing for them to test you on. We don't know exactly why it happens. Even if they're symptomatically unilateral, if you look at the other side, 25% will have bilateral effusions, which can be another clue as well. You know, if there's anything else like fever, elevated white count, elevated inflammatory markers, you need to be thinking about infection. These generally respond well to NSAID therapy. So if they had asked you, like, what is the next best step? You would say naproxen. And then they generally get better quickly. They can recur with infection is one good thing to know, but then they just get better with NSAIDs. Questions? Cool. All right, 3-year-old Caucasian girl was recently diagnosed with Oligoarticular JIA. Her ANA test is positive. Which of the following eye complications is she at the greatest risk of developing? I feel like I need Jeopardy music. All right. 5 people. I don't remember how many did last time I didn't see. But everyone who has responded so far is correct. It is chronic painless anterior uveitis. This is just a, as Dr. Stallworth would say, database. But you might get there, at least the chronic and painless part, by knowing that these kids need oligoarticular JIA patients need frequent screening exams by ophthalmology because they can have inflammation there and not even know it. So that might have helped you get to the right answer. So in general, oligoarticular JIA is the most common JIA subgroup. Oligoarticular means they have less than 5 joints. It's girls more than boys. Most common presentation would be a blonde-haired, blue-eyed little girl with a big knee. Knee is most common, followed by ankle, then wrist and elbow. It's rare to have a hip. And then we check ANA in these patients, not because we think they might have lupus, but because if your ANA is positive, you're at a higher risk of developing chronic anterior uveitis, which happens in 20 to 25% of them.
Then that rare in the hip, going back to transient synovitis, like don't lean towards that on the test.
Yep. So for all of the JIA subtypes, I pulled these from a JIA lecture I do, just kind of a one slide overview to help you remember about them. And I can send these out to y'all too, if that's helpful. Uveitis complications you can get include Synechiae, which is a fun, fancy word for this scarring that you get of the iris, making the pupil irregular. This eye also has a little bit of cataract. You can see in that kind of cloudiness in the middle. So they can have, the unfortunate thing is every once in a while the uveitis occurs before the arthritis, so they don't even know it's been there and haven't been looking for it, and they can get pretty bad eye damage. I don't have a specific polyarthritis question, so just to remember, when you're dealing with polyarticular JIA, you kind of differentiate again between rheumatoid factor positive and rheumatoid factor negative patients present a little bit differently. RF positive patients are more likely to be older and act more like adult rheumatoid arthritis. Multiple symmetric joints, they can get rheumatoid nodules, morning stiffness, all of the usual stuff. And then rheumatoid factor negative is more common again in the little kids, also more common in girls, less common to get uveitis, but if they have a positive ANA, they're still at pretty significant risk. They can get TMJ involvement, which can give them micrognathia, something they could show you a picture of. Their C-spine can also be involved, which can be kind of unfortunate. So those are just kind of very brief overviews of those. Or I think like long they have a higher risk of heart disease. There aren't any other big significant, they usually don't have eye inflammation. No other big associated. Good question. Alrighty. 9-year-old girl presents with joint pain and swelling. She has diffuse swelling of her left third toe, a swollen wrist, and a swollen elbow, and has limited range of motion in those places. You also notice she has pitting of her nails. Her mom is followed by a dermatologist for a chronic scaling rash. Her RF is negative, she's ANA positive, and her SED rate is slightly elevated. So which category of arthritis does she best fit under? Put it in, pull everywhere. Be a participant. Use your brain. Commit to an answer. All right. The 5 people who are participating in Poll Everywhere, the majority of folks got it right and said D, psoriatic JIA. So basically, this question is telling you about psoriasis without saying psoriasis, right? Which is something I feel like boards likes to do a lot, like give you a description of something without exactly telling you what it is and expecting you to figure it out. So the diffuse swelling of her toe, does anybody know what that's? called. Dr. Holloway does. That's dactylitis, which is something common in psoriatic JIA. And then the nail pitting is something commonly seen with psoriatic JIA. And the fact that mom has a chronic scaling rash is probably psoriasis. So it's common to have first degree relatives who have a history of psoriasis as well.
You guys get that.
This is the other place it can happen. So here's kind of the big picture way I think about JIA. If you have a few joints and it's early onset, you're more likely to be oligoarthritis. Extended oligo just means they presented as an oligo in the first 6 months, but then got more than 5 joints late after that time. Later onset patients with only a few joints, you think about enthesitis related arthritis, which we may or may talk about more in a minute or two. Polyarticular, you think about seronegative or seropositive, and when they're seronegative, you make sure they don't have any risk factors or maybe fall into the psoriatic category like this patient. And then systemic is its whole separate ballgame, which we'll talk about more in a minute too. Okay. So to have psoriatic arthritis, you have to have arthritis and psoriasis. Or you can have arthritis plus, you have to have at least 2 of these, dactylitis, nail pits, or a family history of psoriasis and a first degree relative, which this person had all 3 of. So there's some examples of dactylitis. There's some nail pitting. Psoriasis can hide in the scalp, behind the ears, so sometimes you have to be looking for it. We talked about all of this. Okay. 12-year-old boy is currently hospitalized with 15 days of fever, rash, and joint pain. The rash looks like you can see there. It seems to get worse when he has fever. He has swelling of 3 PIP joints, his left elbow and his right knee. He has an elevated white count. He's a smidgy anemic. His platelets are high, his CRP is really high, and his ferritin's a little high. Which of the following is he at greatest risk of developing? Only 3%. Thank you. So what does this patient have? Systemic JIA. Spiking fevers, salmon colored evanescent rash, are the buzzwords. I feel like we're just getting away from the usual buzzwords, but that's what it looks like. Rash comes along with the fevers. The rash and fever can start before you get the arthritis. This is an autoinflammatory disease as opposed to autoimmune antibody mediated. So it acts and looks very different than the other subtypes of category. So they are at risk for macrophage activation syndrome. This is why whenever I ever talk to ER doctors or general pediatricians, this is the one thing that I harp on, because MAS is like life-threatening badness, big deal. Cytopenias, liver failure, PIC, coagulopathy, bad news bears if not treated. So that is what patients with systemic JIA are at risk of developing. Patients with other autoimmune diseases are at risk for developing it too, but specifically and especially systemic JIA. They are most at risk early on in their disease course, or if you're trying to come off medicine or change medicine, also be triggered by infection. So something to know about and be aware of. If your systemic JIA comes in with new high spiking fevers, they need labs checked every time. I think I already said all of these things. Yes. Questions? Uh-huh.
A lot of times with pictures, like, I feel like the boards will throw a picture up that's not very good, and you're like, I can't tell what that is. But the whole point is they're just saying, think of the rash as part of it, right? Like, sometimes you don't have to actually interpret a picture. At least I just remember one online that was like that. It's more about where it was located, the general appearance, plus everything else in the question.
Okay. Here is this little screen slide picture. Can really occur at any age. In adults, it's called Still's disease. All right. Blah, 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 blah. All right. Which of the following is true about children with lupus? The prevalence of lupus nephritis is lower in children than in adults. Pediatric patients should not be on hydroxychloroquine due to the risk of retinal damage. Pediatric lupus tends to be less severe than adult lupus. Pericarditis is the most common cardiac manifestation of lupus in adults and children. And the ANA test has a high positive predictive value for lupus. Okay, a few people say D, a few people say E, somebody says C. All right. The correct answer is D. So lupus nephritis happens more in children than in adults, and pediatric lupus is generally more severe than adult lupus. Everyone needs some vitamin P, a little Plaquenil in their life. We do think about it a little bit more carefully because of the kind of cumulative risk of retinal damage. I feel like in adult rheumatology world, they'll throw everybody with a positive ANA on a little hydroxychloroquine. We don't do it quite that willy-nilly, but if you have lupus, you need to be on hydroxychloroquine. An ANA does not have a high positive predictive value for lupus. It is positive in up to a third of completely healthy children. So please don't tell everyone with positive ANA that they have lupus.
You laugh, but I had 3 patients the year I did it that came in crying because they're dark people and they had lupus.
Yes, it is a.
Unless I missed 3 patients.
I've since seen those patients. There's a high sensitivity. But I did have one patient in fellowship who's like the worst lupus ever, who had a negative ANA. Okay. But she had like real class 4 lupus nephritis. Anyway, okay. 26-month-old presents with rash and joint swelling. The rash started first about 4 months ago. This one's kind of hard. It has mainly been on his trunk and limbs. It's little bumps that are pale pink and barely palpable, and at times has had some mild desquamation. He has symmetrical polyarticular arthritis in his wrists, knees, ankles, and PIPs with impressive swelling and synovial proliferation. Despite these symptoms, he doesn't really complain that much of his joint pain. He was recently seen by ophthalmology after developing nodules in his conjunctiva and was diagnosed with uveitis. You are suspicious he may have pediatric onset sarcoidosis. What gene do you test for? All right, great job. So a little over half of you said B, which is NOD2, which is correct. Ding, ding, ding. This is also called Blau syndrome. So basically it's in the autoinflammatory family of things. This genetic change causes increased granulomatous inflammation similar to in sarcoid. But it definitely looks different than adult sarcoid, right? You're not talking about potato, hilar lymph nodes, and all of that good stuff. The main characteristic that they always talk about is this boggy synovitis, which is basically just saying like big squishy joints, but that aren't actually that painful. They get this papular erythematous rash. They can get terrible uveitis. That's pan-uveitis as opposed to anterior uveitis. Not to be confused with pediatric onset adult sarcoidosis, which acts like adult sarcoidosis. Sarcoidosis was one of the 10 things, and this is the most likely way it presents in kids. Now you know, you will get it right. Got it, good, questions? NOD2 is also a mutation seen more commonly in kids with IBD, but I think it's a different mutation in the NOD. Okay. 9-year-old girl develops a purple rash around her eyes. She also has had a rash on her knuckles and elbows that her pediatrician said was eczema and has been treating with steroid cream. She's having trouble keeping up with her friends in PE class and has been very whiny about going up the stairs to her bedroom. What long-term complication of this illness is she most at risk of developing? Excellent test taking skill. Dalton said this can't be lupus because I already did lupus. This is not lupus. Dalton is right about that. Only 2 people have responded. So what do you think she has? She has dermatomyositis. Yep, so heliotrope rash, Gottron's papules. I see kids all the time, they're like, she's had this eczema that won't go away on her fingers. And then proximal muscle weakness. So this is something I've heard numerous times too, is like parents who are like, he's been so whiny and complaining that she doesn't want to go up and down the stairs. But then one day she crawled out of her school and I said, something must really be wrong. So myositis. So what are these patients that develop at risk of developing? The answers are a little bit all over the board. And only one person got it right. Nope. Calcinosis. Yep. So calcified like nodules subcutaneously, which can be really, really challenging to treat, really painful. They happen at pressure points. So often on the elbows, on the booty, can like leak out this nasty like milk of calcium stuff. But juvenile dermatomyositis, proximal symmetric weakness, the characteristic cutaneous changes, which we'll look at pictures of, elevation in your muscle enzymes, and then you have to have some evidence that you have myopathy. So the old diagnostic criteria said that you had to have either an EMG showing myopathy or a muscle biopsy. But nowadays, we just get an MRI of their thighs and show that they have muscle inflammation. So these are Gottron's papules. This is a heliotrope rash on her little purple puffy eyelids. And this is some examples of calcinosis. Calcinosis happens if their disease is uncontrolled or as a like late manifestation. So this is not something they'll present with initially, but then will often develop later on, especially if they're not treated aggressively or unable to get good control of their disease. I think some people will even use like bisphosphonates and craziness. You can excise them, but then you run the risk of, dermatomyositis. Same with the calcinosis. Dermatomyositis you treat with IVIG, pulse steroids, methotrexate, and oral prednisone as like the first line, like for months and months and months. Then sometimes other biologic medications We usually treat them for at least 2 years without stopping, I mean, like tapering things down, of course, but they'll be on meds for at least 2 years before we try to come off of them. All of those things. All right. Which of the following should be addressed to treat amplified musculoskeletal pain syndrome? This is easy. All of the above. So amplified musculoskeletal pain is the fancy word for fibromyalgia and syndromes like it. Patients with fibromyalgia present with diffuse, widespread musculoskeletal pain. They usually have fatigue. They usually either say that they don't feel rested when they wake up, or they have disrupted sleep. They can't fall asleep. They wake up a bunch. There is a fair amount of evidence that shows that these patients have central sensitization, basically meaning that the volume on their pain nerves is turned up. So, and the neurotransmitters involved in that process are the same ones involved with mood symptoms, anxiety, depression, sleep, and physical activity. So those are the initial things we do to address amplified musculoskeletal pain. Headaches are common in these patients too. CBT helps, exercise helps. Sometimes they need antidepressants. Sometimes they need other medications. There's also, I'll just give one little plug for complex regional pain syndrome, which is a little bit different and y'all may have seen before. So this is severe pain with like hyperalgesia and allodynia, but just in one location, usually an extremity. They can also have color change and temperature change there. It is treated with desensitization exercises, often also CBT. These things put you at risk for one another and are kind of similar in their amplification of pain. Makes sense? Right, this one we can't really do the poll everywhere. Well, these are the major manifestations of acute rheumatic fever, at least the ones in the Jones criteria. So rank them from most to least common. No, you don't have to do it on poll everywhere. That certainly makes sense. What is the most common? Arthritis is up there with one of the other ones. Carditis, yep. Syndrome chorea is about 15%, is what my textbook says. I've only seen it once. And then erythema marginatum and subcutaneous nodules are actually both really, really uncommon. I've never actually seen either of those. I've seen a fair number of acute rheumatic fever patients. So carditis and arthritis are the most common things. How does the arthritis present? Migratory polyarthritis. It'll be, my knee was swollen for a couple days and it was really painful and I couldn't walk it, but then it got totally better and now my elbow is swollen and really painful and I can't move it. The pain's generally pretty significant out of proportion to their exam. So just know what the Jones criteria are. There are also the minor criteria, which almost every time I've diagnosed a patient with rheumatic fever, I've had to also use the minor criteria to get there. So be aware. All right, last question. 13-year-old boy is being treated for left knee arthritis. He also reports pain at his Achilles insertion. Father has a history of inflammatory bowel disease. Which category of JIA does he fit best in? All right, most people got it right, and it's enthesitis-related arthritis. So this is the pediatric version of the bigger category of like spondyloarthropathies, ankylosing spondylitis. These are the patients usually who are positive for HLA-B27. They get arthritis, but also enthesitis, which is inflammation at tendon insertion sites. And can eventually develop ankylosing spondylitis with spine SI involvement. I see patients presenting with SI joint involvement a decent amount, but kids don't usually get the actual like ankylosing spondylitis spine stuff. Inflammatory bowel disease is another thing that runs in this family of conditions. So go back to this kind of overview of things. You'll see it's there in the more, it's usually more oligoarticular, but older kids, and especially in boys. Hopefully, it's definitely a more likely to be a chronic arthritis than some of the other kinds of JIA, which they'll sometimes throw out of. It can be challenging, more challenging to treat, but we do our best to control our inflammation to not get spondylitis. That's all I've got.
Thank you.
You're welcome. Definitely. Yep. 2%.
So I guess sports medicine orthopedics is 4% is what it said. Let's see. So the first one on this one is a 6-year-old female was brought to your office for recurring limp pain. 2 weeks, she's been complaining of cramping in her thighs and calves. Wake her at night, massage and Tylenol help. Morning symptoms are gone, and the daily activity is unimpaired. Physical exam normal, no signs of issues on it. What's the next appropriate thing? Radiographs, SED rate, CBC, ANA, or no further testing. This is obviously one of those that you are doing as far as thinking through what the diagnosis is and then making a decision. So what is this? Growing pains, right? So what do you do for that? Nothing. Anytime there's no further testing, always just think about that. Like, not that that's always the answer, but almost every time I've seen it, when it says that, it's unless there's a reason, and I'll show you a couple of examples that they could put that in there. But so yeah, growing pains and all those are typical things in it. This is a 5-year-old white female with in-towing, excessive femoral anteversion. She's otherwise healthy, mobile. Parents generally concerned about the cosmetic appearance and future disability. They request that she be treated. So what do you do? Just observe. Medial shoe wedges, torque, sleeping in a splint for 6 months, or derotational osteotomy of the femur. What's that? Yeah, so that is actually a treatment of like, that is a thing, but not for this patient. But that's like the older patient that's having a lot of trouble with.
Dr. Holloway, we're seeing just like your email screen with like where you maybe you open the PowerPoint from, but not the actual PowerPoint slides right now.
Gotcha. Share.
What's that green bar on top?
All right. Now, can you see it okay? I'm assuming so. So what do you guys think of this?
We can see it fine now.
But yeah, this is up to date. Just think of it like I said, just think it's like that appropriate. And actually the data nowadays says it is, and that splinting used to be stuff we would do. And I actually wore one when I was little, but now they basically are just considering it torture because it doesn't do anything. But that bar is like where it keeps the feet like straight. But yeah, the newer thing is saying you don't have to really deal with it unless there's an extreme thing. So again, do something like when you get up to like there's certain ages for each one, and that's kind of the curve. But like 8 is when you get into like 8 and older is when you start to think about like maybe I should send it to someone if this is like the first time I'm seeing it, and then I want to refer it to someone. Surgery is 8 to 10. Right there, and that's what most of them do want to treat, right? They want to do what's best for their kids. So the key is on that being very forthcoming because that's what we refer to this. They're not going to put them in point because that's what they do. But yeah, just trying to, and that's where there's never anything wrong with referring them to someone like me, but no, just like with the lupus thing, don't set us up for failure. Like saying, oh yeah, I'll send you to them. Take care of you. Say like, we'll probably need to observe you, but you're getting closer to 8, and they'll watch you over time, that type of thing, just so they know. Does anyone remember where Little League elbow is? So yeah, medial epicondyle. So that's, again, it gets into that world of the apophysitis. So remember those as being things in the younger kids. Things, what's the one in the heel? Severs, yeah. There's a whole category of those to kind of always think about, and then treatment-wise, they're similar, but knowing that that's an entity is a lot of times what they want to get at. And there's a lot of little ones that we deal with, and again, those are most of the time the treatment of those are pretty straightforward. Physical therapy, relative rest. So little leaguer's elbow comes from throwing too much. This one is basically a female who inverts her ankle. She's got exam shows pretty bad ankle sprain. In addition to rehab, you advise. And this is where it gets a little bit weird because you've probably seen people get put in all of these things, right? Like, and that's where when I read this question, not knowing what's best, you kind of have to think about what is best. And of course, when I made this question, I put E on there just to throw you off, because this is again where you don't just not do anything just because you don't know what to put on it. But if you're generally thinking, how do you think about like ankle sprains and like sprains in general, what are you trying to do? With immobilize, yeah. So then you think about, okay, does they need a cast? Well, cast is a long-term thing, so that's probably not good. Posterior splint, well, how's it? Yeah. And so that's where you get C, is the air stirrups on the edge, right? So that makes sense, everyone? So this is a 15-year-old runner who's got patellofemoral syndrome. So this is again where they're telling you the diagnosis. Now this is where you're understanding that diagnosis is more important. So you got prepatellar pain with running, knees stiff. So this is actually asking you which of these doesn't fit that category, and therefore you would probably want to send on: popping, locking, or positive J sign. So basically, which of the following doesn't fit patellofemoral? Say it again. Locking. Yeah. So what does that make you think more about? Yeah. Yeah. So something that's keeping the joint from moving. So popping is not unusual. Again, stiffness is very common after you're sitting. So all these other ones are really common with patellofemoral. So again, they could kind of not tell you that and say which of these would make you want to refer to. There's a 5-year-old who's brought into your office because he fell. He's diagnosed, so the radiologist comes back and says he has an non-angulated buccal fracture of the distal radius and ulna. Which of the following is the best functional outcome at 3 to 4 weeks? So again, this is where
this is kind of goes to the other end of the spectrum. You got E in there that says refer, but I specifically put for surgery, right? So that's where you got to know that this doesn't need surgery. Now, sometimes they'll say refer to ortho, which, like I said, in real life is never a bad thing long term. But then again, the way that they're trying to ask the question is what's the best functional outcome? And you could also think of if you refer them, they might not get in within a little bit and whatever, they need some treatment right now. And this is just one of those trying to think through it. And there's actually a big article about this, that buccal fractures. Does everyone remember what those are? So the buckle is where it just like buckles down. So instead of breaking when they fall, it just literally goes like that. So instead of being broken, it's just like bent, right? And that's not like cracked in two, right? So what you gotta do is like splint it a little bit. And that's where removable splint is just as good as and stuff like that. And that's different than green stick, but the same as torus. So torus is the other name for buckle. So this is a 20-year-old that falls, has an MRI basically showing a rotator cuff tear. This is where you'd say, okay, what's the best initial treatment for this injury? Again, this is where thinking through all these, and then I think this is where knowing the definitive diagnosis and treatment of an acute tear of a rotator cuff muscle, there's only one treatment of that, surgery. Yeah. I don't want to say like never send to the surgeon on a test, but there's times, and this is just another example where they could phrase it in a way that says they fell the knee. The X-ray shows a displaced fracture of the tibia of the physis and epiphysis. So does anyone remember what that would be? Because the other way they could ask you is what is the diagnosis of that? What's the name of that fracture? A fracture through the physis and epiphysis. Filter is tight. 5 is the crush one, and I'll show you a picture of it. 5 is the crush. What is 1? So 5 is the smash or the ER. Because you can use the word Salter.
Yeah. No, you can't. Salter is two in the way.
It looks yeah, it's the same. So it looks the same. So it's actually straight, or I think of straight through the growth plate. So you don't actually see anything. And then that's type 1. I'll show you. And this one is just another example where they say displaced fracture. So again, you wouldn't want to just immobilize a displaced thing. That's where someone's gonna have to put it back in its place. So this is, oh, sorry. This is yeah, you don't have to see the top. It's right here. Just try to zoom in.
Yeah.
This one? The last one was surgery because it was displaced. So if you ever hear like displaced, dislocated, those things, that's where something's going to be done where they want you to get the definitive treatment. The other thing is the Montega Galeazzi fractures of the forearm. Those are fracture dislocations. So again, unless you know how to relocate them and put it straight, make sure that someone's doing that, not just here is a splint would be good. Versus the buccal fracture, you can take care of that. So again, what kind of fracture would this be? So sometimes they just show you the picture. And this is, I'll show you the thing. So again, this is where thinking through the anatomy of it. This is the joint, right? Here's the fracture. Here's the physis, the growth plate, and then there's the fracture. I'll show you again with the pointer. Obviously, then you would know it's Salter Harris, but now they want you to go 2 or 3. So this is S is straight through, and A is away from the joint.
Great.
A in the word Salter. So type 2. Does that make sense? Let me just show the picture. Make it make sense too. So this is again down here. Remember that it can be flipped, right? So we're talking about bones, and there's the epiphysis, physis, and then metaphysis, right? And then 1 is straight through, 2 is away from the joint, Does that make sense? But it can be flipped. So up here, because some people say above, but if this would not be like whatever, you know what I mean? So you think away from the joint. Yes, and so this one was away from the joint. This is a 2. Does that make sense? And 3 would go towards the joint, so it'd be like right here. 4 is through both, and then ER. So if you use the word Salter, S-A-L, the lower part. Does that make sense? This is a 15-year-old with bilateral foot pain. Exam shows basically some rigidness. So you see rigid flat feet. So now we're not just saying he just has flat feet, he has rigid flat feet, tightness. And so this is understanding, why do we care about rigid flat feet? What's the most common diagnosis in rigid flat feet? Does anyone remember this? Do you remember what that is? Yep. So it can be a cartilaginous or bony coalition. So yeah, that's that. If you hear rigid flat foot, that's like number one thing you got to rule out. So again,
What do you like? What is rigid? So if you go to stand on your tiptoes, you should see an arch come out. So if they have flat feet and they stand on their tiptoes and the arch comes out, then it's flexible. And that means it's just flat. Right. Right. I mean, unless it's extreme, unless it's some of those things, then you're just doing arch supports and stuff like that. But when you have a rigid, like it feels like the foot is stuck in that flat foot. And sometimes it'll be like one is not too flat and one's like extreme, but it can be bilateral. With this one, yes. Yes. Yeah, so they're just kind of like, oh, they just have flat feet, they have flat feet. Now it's starting to hurt because it's getting more like sucked in and then they're growing. So a lot of times they'll come in saying like, oh, he grew a lot. I'm gonna skip this one. That one's the answer on the other one. The tarsal coalition, yeah. So that one was just kind of about Osgood Slaughter's understanding knee pain, so you kind of understand where it is. Understanding basic components of patellofemoral syndrome and stuff like that is very important. This is then getting into back pain. And so this one is where you get, basically they told you it's spondylolysis. So again, on this type of question, you don't even need to read the whole structure. It's just like they have spondylolysis. Then it's saying, what do we do with these? And then kind of, this is where these are tough versus, but then generally thinking about what you would want to do in these situations. Does everyone know the difference between the spondylolysis and the spondylolisthesis? Yeah, like the shifting. So listhesis means like the slippage. Lysis means stress fracture. Yeah, I got a picture of that. And basically they just want you to kind of know that inadequate treatment can lead to problems, right? So that makes sense. Bracing, yeah, and then physical therapy usually. So again, the difference between a fracture and then the slippage. And these are going to be more the athletes like that do back extensions, so offensive linemen, gymnasts, those sort of things. That's just, remember the Scotty dog sign there, that you have to get an oblique film. So then just some of the other injuries that happen to some of the other sports medicine, so not musculoskeletal type stuff, but this is understanding that. Which one of the following is a contraindication to participation in contact sports? So this is again goes to that pre-participation physical understanding, and then what you would do, and understanding why you would do that.
What do you guys think? Fever, yeah. So fever is actually that like, that's what, I mean, you hear about like Michael Jordan playing with the flu and stuff like that. But again, this is where kids, fever, you don't let them play sports because of what? Right. So all the other ones are like relative. And so like with a single testicle, you'd be like, okay, maybe you want to bang some sperm, maybe you want to wear a coat. That type of thing. Sickle cell trait, there's some modifications, but they can still play. Scoliosis has to be really bad, and then hypertension has to be like the high stages. Just because you don't know, like, so you have fever and it's like you have something. There's an 18-year-old female long distance runner presents for a 3-month history of amenorrhea. Pregnancy test is normal blood work, no other things, no meds. So with respect to her amenorrhea, what do you advise her? To increase her caloric intake, that this is a normal thing with training, to use contraceptive, stop running, or see OBGYN. Okay, and why is that? Good, so this is the female athlete triad, which is where you're gonna have to increase the caloric intake for this not to happen. So he is like the response of just just stop doing that, but that's never really the response to things unless there's a contraindication, right? So this is where increasing the caloric intake should fix her amenorrhea. In a pre-adolescent athlete, sudden cardiac death from a blow to the chest, commotio cordis, is most likely in which of the following situations? This is again kind of a database question. So they could ask you a little bit different about commotio cordis of a kid does get hit. What's the first thing you would do in that situation? If you're at a ball field. What's that? Yeah, but then what's a little bit different about this situation that like you would do in an adult, but you don't always think about in kids? Well, getting the yeah, so he has a cardiac thumb, so then you were wondering, it threw him on to VTAC, so like hitting him against, so that's where getting the AED to shock him. So the few times, but this most common happens with baseball. They sell little pads, like I got my son one, but they're actually not clinically proven to do anything because it's the fact that their chest is so pliable that it lets it impact their heart and throw it into VTAC. And the last few, this is a female who wants to play volleyball. She's really tall. Her arm span is greater than her height. She has myopia. Which one of the following needs to be performed? So what does this patient have? Or what are you worried about? Marfan's good. So what do you, so this is where again, you know, trying to make sure you do what's best, but what falls into the realm of deciding if she can play or not. That goes. This is where you don't want to go just basic EKG. You want to go, but you don't need to go extreme. Like this one, I mostly just wanted to, instead of reading it all, just show you real quick about these, just to throw you into it. There's mallet finger, remember, where you just got bumps right on this, and then they walk in and they can't straighten their finger because it tore off that tendon. Boutonniere's deformity is when they dislocate or hurt the more proximal joint, and then you can get the swan neck deformity, which sometimes happens with arthritis and stuff. Do you see that much in kids though, or is it pretty advanced?
Usually it's more advanced. Lupus patients can get
And then just remember with mallet finger, this is an easy treatment where you just put them in a splint to hold it straight, and then that will form. This is the opposite of jersey finger, where someone is grabbing and then it tears the flexor tendon, and then they can't bend it right, and then that's a surgery, like an urgent referral for surgery. So like similar injuries but very different treatments. So they like to ask about that question because one is like get them to a hand surgeon, one is just put a splint on them. Yes. Right, they can't, it's this tendon, so they can't. It's not the extensor, it's the flexor. And that just like, you can't put that back unless you pull it and surgically tie it down. So they wouldn't be able to bend. Yes. Yeah. And then the last one about concussions. This is where I've seen it asked a few different ways and trying to figure out the best way to phrase it too. This I pulled straight from a one that I saw. So basically trying to figure out what's the best way. So 24 hours of rest, or do you just tell them to rest for a certain amount of time? I hope most of you understand that just telling them to rest for 1 week is not appropriate at all. Otherwise I wouldn't have a clinic. Rest until asymptomatic is a thing that used to be said, but then we've gone away from that. Rest and then wait till all your symptoms go away before you go back used to be a thing too. Now we've gone away from that. Resting and then wait till your symptoms are better and really good versus just go ahead and start easing back into stuff is the part that we're trying to figure out more. And then this is A, because it really is just 48 hours of rest. And then when we talk about gradual threshold back, we're not saying go play football in a week. We're saying go to school, do like walking, stuff like that. And so that's why the way they phrase it can be weird, but it's understanding that that's the newest information about concussion. That makes sense. Any questions for us? I always think people are going to chime in on online, but I don't know, it's always hard to tell if they're even paying attention.
Okay.